All right. Hello, everyone, and thank you for joining us if you're listening into the live webinar today. My name is Amy Webb. I am a senior public health analyst with the Division of Healthcare Quality Promotion, and I am on the NHSN AUR module, or Antimicrobial Use and Resistance module team. Today, I'm going to be talking to you about the antimicrobial use option, or the AU option. So my objectives for today are to first outline the requirements for participation in the AU option, discuss the data elements collected in the AU option, and describe the analysis reports that are currently available for you participating in the AU option. For those of you that may not yet be participating in the AU option and you're kind of curious to know how that fits in with the rest of NHSN, this slide has the current NHSN structure. You can see there are quite a few components. So within the patient safety component, many of your facilities are probably already using the patient safety component to submit your HAI data. The AU and AR options are housed within the AUR module. So today we're just going to be talking about the AU option. So first I want to cover the AU option reporting requirements. The AU option was first released in NHSN in 2011, so we're getting close to 10 years in NHSN now, so we've been growing quite substantially, which is really exciting for us. The purpose of the AU option is to provide a mechanism for facilities to report and analyze their usage data as part of their stewardship efforts at their facility. I do want to point out that reporting into the AU option is completely voluntary at this time. It is not part of any CMS quality reporting programs. However, it is just one option for the public health registry reporting for the Promoting Interoperability Program, which was formerly called the Meaningful Use Program. So if your facilities participate in what used to be Meaningful Use, now is Promoting Interoperability, you can use submission of AU and AR data to qualify for just one of those program requirements. However, you can meet all of the Promoting Interoperability requirements without submitting into the AUR module, which is why we say submitting into the AU option is technically voluntary at this time. So just a quick note for those of you that are interested in participating in the AU option to meet the CMS Promoting Interoperability Program requirements, you must submit data for both AU and AR options to get that credit. So I have the steps for participation listed here on the slide. As a prerequisite, you must use a certified vendor software. So you can go to the link on this slide and check to ensure that the vendor software you're using has been certified. Then you would register your intent to submit within the NHSN application. You would send us your test files and we would validate those and send them back to you and say, these look good. And then finally report your production data. For facilities that are interested in this, we do have a resource guidance document at the link on this slide. You can find that on our website. I do want to point out that the AUR module is the only part of NHSN that qualifies for counting as part of the Promoting Interoperability Program. So even if you submit other HAI data via CDA to NHSN, that does not count. Only data submitted into the AUR module counts. All right, so if you're not yet participating in the AU option, hospitals that have either the Electronic Medication Administration Record, or the EMAR system, or the Barcoding Medication Administration, BCMA system, as well as the Admission Discharge Transfer System, can participate. So those are the two electronically captured numerator systems, the EMAR, BCMA, and for the denominator, we get that from the ADT system. Facilities must also have the ability to collect and package those data using the standardized HL7 format of clinical document architecture. And we'll go more into that on a few future slides. The vast majority of facilities submitting into the AU option right now do use a commercial software vendor to submit these data. The Society for Infectious Diseases Pharmacists website hosts a list of self-reported vendors for vendors that have either successfully submitted with client facilities or are in the process of doing so. So check out that link if you're looking for a vendor or to see if your current vendor offers these capabilities. It's also possible to use what we call a homegrown solution. So basically the facility's internal IT or informatics resources do all of the coding and development of the CDA files to submit the data to NHSN. While that's possible, it's not often feasible for most facilities. So if you're interested in pursuing that route, we highly recommend first speaking with your IT or informatics resources, and then second, reaching out to us to kind of have an initial call to kind of walk through what that would look like for your facility before you get too far down the road. For our AU option, we have a numerator of antimicrobial days, also known as days of therapy. This is simply the sum of days for which any amount of a specific agent was administered to a patient. We currently collect data on 91 different antimicrobials. This includes the majority of antibacterials, some antifungals, and some anti-influenza agents. In addition to reporting the total antimicrobial days for each of those 91 drugs, we also have facilities submit antimicrobial days by sub-stratified route of administration. So the 4 routes of administration that we collect in the AU option are IV, IM, digestive, which includes any administration in the digestive tract from oral administration to rectal administration, and then finally respiratory or your inhaled antimicrobials. I do want to point out that we only accept administration data from the EMAR or the BCMA system. We do not accept pharmacy orders or billing data. So just to walk you through how we count antimicrobial days, so you would assign 1 antimicrobial day per patient, drug, location or unit, and calendar day. So I want to point out that's regardless of how many administrations a patient receives of that single drug in that calendar day. I have an example here. So in my example, my patient was admitted to my 1 South medical ward on Monday evening and discharged on Wednesday afternoon. That patient received meropenem every 8 hours and amikacin every 24 hours. So on Monday, that patient got meropenem once and amikacin once. Therefore, they get 1 total antimicrobial day for meropenem and 1 total antimicrobial day for amikacin. On Tuesday, that same patient received meropenem 3 times and amikacin just once again. However, you'll notice that in the total antimicrobial day counts, that patient still only attributes 1 antimicrobial day for meropenem. And Wednesday, they just received the meropenem in the morning, so they would attribute 1 total meropenem day and 0 amikacin days since they did not receive amikacin on that calendar day. Next, walking through the counting of antimicrobial days for each of our substratified routes. So very similar to counting the total antimicrobial days, to count the days per each route, you would get 1 antimicrobial day per patient, drug, route, location, and calendar day. So you can get 1 total antimicrobial day for the drug and 1 antimicrobial day for each route for that calendar day for the specific drug. So I'll illustrate that in another example here. But I do also want to highlight that the antimicrobial day is counted on the day of administration only. So if there are instances where you're doing an infusion that takes longer or it crosses 2 calendar days, for example, you only attribute the antimicrobial day to the patient when the antimicrobial was first administered. Okay, so in my example here, my patient was prescribed ciprofloxacin twice daily. On Monday, they were admitted and just given it via IV. So their total antimicrobial days, they attribute 1 total Cipro day, and then they get 1 IV Cipro day. On Tuesday, that patient received their Cipro via IV in the morning and via orally in the evening. That patient still only counts as 1 total Cipro day, but they would attribute 1 IV Cipro day and 1 digestive Cipro day. And then on Wednesday, they received Cipro just once via oral route. So they would get 1 total Cipro day and 1 digestive Cipro day. So when you are reviewing your data and you're looking at your total antimicrobial days and your routes of administration, you cannot sum the routes to be able to come up with your total. So it should be a separate calculation. Like in our example here, for drugs that are given more than once a day via multiple routes, it's very likely that your total antimicrobial days will be less than or equal the sum of the routes. So in the highlighted box here, you can see that we had Cipro total antimicrobial day was just 1, but yet that same patient was able to attribute 1 IV Cipro day and 1 digestive Cipro day. All right, so moving into our denominators. For the AU option, we have 2 different denominators. The main denominator we use is days present, which is simply defined as the number of days in which a patient spent any amount of time in a specific unit or facility. I do want to point out that days present is reported for each of your individual locations, as well as FAC-wide in. So FAC-wide in stands for facility-wide inpatient. So for those of you that don't report HAI data to us, you might be unfamiliar with that concept, but it's basically all of your inpatient locations combined into one record, one count for each of your drugs. Days present, if you were paying attention to the definition, is not the same as patient days, and therefore they will not be equal if you're comparing your patient days to your days present. So remember, patient days, you're counted if you are in the location at the time of the once daily census count, whereas days present, you're counted if you're in that location for any time during that calendar day. So in most cases, your days present will be greater than your patient day counts. We use days present in NHSN for AU option data only. Patient days is really used pretty much throughout the rest of NHSN, which includes all your HAI reporting and your AR option reporting. And then admissions is our second denominator. That's just simply defined as the number of patients admitted to an inpatient location in the facility. We collect our admissions data for FAC-wide in only. So basically that means we do not get location level admission counts, only for the grouped variable of FAC-wide in. And our definition for admissions is the same definition that's used throughout the rest of NHSN. So I'm going to go over an example here that can help with illustrating counting days present and how that compares to patient days. So on the left-hand side, I have my patients, my patient movement. And then on the right-hand side of the slide, I have my 2 denominators, days present, which is used for AU, and patient days, which is used for HAI. And for our example, assume that the patient day count is done at midnight. So patient A started and finished the day in the medical ward. That's a simple one. They would get 1 day present, and they would also get 1 patient day. Similarly, patient B spent all day in the medical ICU. They would also get just 1 day present for the medical ICU and 1 patient day for the medical ICU. So patient C moved a little bit. They started the day in the medical ICU and then ended the day in the medical ward. For our AU days present denominator, that patient attributes 1 day present for the medical ICU and 1 day present for the medical ward. However, for patient days, remember we're looking to see where the patient is at the time of the midnight census count, and the patient was in the medical ward. So they would attribute 0 patient days to the medical ICU because they were not in that location at midnight. And they would get 1 patient day to the medical ward because that's where they were at the midnight census count. So you'll notice here's our first opportunity for difference in the days present and patient days counts. That patient, because they were in the ICU at some point during that calendar day, would attribute 1 day present to that denominator for the medical ICU. And then patient D moved around quite a bit, started the day in the ICU, then moved to the step down for a little bit, and finally ended the day in the ward. So you'll notice in our days present column, that patient gets 1 day present for each of those locations because they spent some time in each of those patient care locations. But for our patient day counts, you'll notice that they only attribute a patient day for the medical ward, since that's where they were located at the time of the midnight census. So again, you'll notice for both my medical ICU and my step down, this patient attributes days present for both of those locations, but 0 patient days for those locations. So when we add up our totals, you'll notice that for the medical ICU and the step down, our days present counts are higher than our patient day counts. And as you can imagine, with the more patients, numbers will become more and more different. So your days present counts should always be greater than your patient day counts, because your days present counts are taking into account those patients that transfer in or out of the location prior to the once daily census count. So our AU option data are submitted monthly. They are a monthly aggregate of summary level data. So when you submit them to NHSN, they are already rolled up to the individual patient care location. So we do not have any patient level information that's already rolled up to the individual patient care unit level by the time it gets to NHSN. So when you submit, you're submitting your data by location for each of your individual inpatient locations. Each of your inpatient locations combined, so that's that back wide in that we were talking about earlier. And then the 3 outpatient locations that we currently accept are emergency department, pediatric emergency department, and 24-hour observation area. I do want to point out that we get this question often. The locations that you use to report your AU or AR data should be the exact same locations that your facility is using to report HAI data. We do not want you to map separate locations in your NHSN facility just for your AU or AR reporting. So this is where it becomes important to work with all of your team members in infection prevention and throughout the hospital to make sure everyone is on the same page with which locations you are using in NHSN. But an important caveat for submitting data is that we require accurate and complete electronic capture for both the numerator and denominator in order to submit data for that given location. So some facilities have trouble capturing numerator data from specific locations. For example, in their operating rooms, sometimes facilities are not able to get accurate electronic administrations that occur in that location. That's okay. We tell folks just don't submit that location when you're submitting your data to us, so you can exclude specific units. But in order to submit your data, you must have both numerator and denominator data electronically captured. So like I already said before, but it's important, so I'm going to reiterate it. Data are aggregated prior to sending them to NHSN. We have no patient level antimicrobial use data in NHSN. So, in the AU option. So in the AU option, we get no patient level antimicrobial use data. All right, so next part of my presentation, I'm going to talk about how you actually submit your AU data into NHSN. So the data must be uploaded via CDA, or Clinical Document Architecture. So as we've already talked about, we currently collect 91 different drugs. So to report the total antimicrobial days and then all of these substratified routes for all 91 drugs would just be way too much data to be entering by hand. Therefore, all data are required to be uploaded to NHSN electronically via CDA. So CDA, for those of you that aren't familiar, is a Health Level 7 or HL7 standard. We use CDA at NHSN to provide facilities with a standardized way to package and upload their data. We currently use CDA for AU and AR, but also a lot of the HAIs can be submitted via CDA as well. So using this standardized format allows us at NHSN to be able to accept the data from all sorts of facilities using all different vendors and IT solutions, so that everyone is putting their data in the exact same formats, so then we can accept it into NHSN. I do want to point out that CDA is not the same, does not equal CSV, or that can look like an Excel file when you open that up. So CDA uses XML programming language. I did include a screenshot here on the slide of just a very teeny snippet of what an AU CDA looks like. So you can see that this takes a specific knowledge of this type of coding in order to even put the CDA files together. So it's not something that many hospitals have the capability or the time to be doing. So that's why many folks use a vendor. All right, so if we're following the flow of data, so the EMR, the BCMA system captures the drug administration when that drug is administered to the patient. The vendor or the homegrown system then extracts and aggregates those data elements. Remember, the numerator comes from the EMR BCMA system, and the denominator comes from the ADT system. Then the vendor system packages those data into the CDA files. And we have one file per month per patient care location or unit. So what does your monthly AU data submission look like? We recommend uploading data within 30 days following the completion of the month. That is a recommendation, not a requirement. That is simply to make the data most actionable by your facility. However, if you get a little behind or you're a new facility and you'd like to submit retrospective AU data, we encourage and highly recommend doing that. So the 30 days is a recommendation to make the data most actionable by your facility. So your actual uploads will contain one CDA file per location or patient care unit, and then one CDA file for FAC-wide-in. Each CDA file contains both the numerator and the denominator, which is nice, which is why you only need one file per location. And you can zip all of those files together in one zip file as long as you are below the maximum requirements of 1,000 CDAs or 2 MBs per that zip file. But the vast majority of facilities will be, so you could submit all of your AU files for 1 month in a single zip file and a single upload. And I just want to point out that we do encourage reporting data from all applicable inpatient and select outpatient locations where you have accurate data. You'll see a little later on in my presentation that some of the analysis reports are available for specific unit types. However, even though that's the case right now, we're always rolling out new analysis reports for you all. So that's why we encourage submission of data from all of your applicable inpatient and outpatient locations. So an example monthly submission for AU, remember I have one CDA file per location and one per FAC-wide-in. So in my example facility, I have 4 patient care locations. So I would have one CDA for my 1 North Medical Surgical ICU, one CDA for my 1 South Adult Medical Surgical Ward, one CDA for my 2 North Pediatric Medical Surgical Ward, one CDA for my emergency department, and one CDA for FAC-wide-in, which would be the combination of the 3 inpatient units above your adult med-surg ICU, med-surg ward, and your pediatric med-surg ward. So those 5 files would be zipped up and submitted to NHSN in one zip file. Once you had your zip file ready, the next step prior to importing your data would be to add your locations to your monthly reporting plan. So the monthly reporting plan is in the patient safety component. You would add FAC-wide-in as one row, as well as each of your individual inpatient locations and any of those select outpatient locations that you're going to submit. And then you check the antimicrobial use box in that column. I do want to point out that this is the same monthly reporting plan used for your HAI reporting. We get that question a lot as well, if there is a separate plan for AU. There is not. It's all in the same reporting plan. So the AU module section of the plan is actually the 3rd section on that page, so just below the procedure associated module section and just above the MDRO module section of the plan. So once you've updated your reporting plans, you're ready to upload your files into NHSN. There are actually 2 different ways of uploading files. The screenshot on the left shows how the manual upload starts. The first part you would do is you would go to the import-export data screen and you would select events, summary data, and procedure denominators. So AU are considered summary data. So here you would browse for the zip file that you've extracted from your vendor system. Maybe you've saved it on your local computer, on your network somewhere, and you would submit that way. Or you can use the second method shown on the screenshot on the right. This we call direct CDA automation. So a lot of vendors offer this now, but not all. So if this is something of interest to you, be sure to reach out to your vendor to see if they support this. But basically, what this is a direct connection between your vendor software and NHSN. So you complete these fields here. There's 4 required fields that you would enter information from using information provided by your vendor system. And then once that's basically turned on, that is you allowing files to come directly from your vendor system into NHSN. So most vendors, or the vendors that offer this, have like a button in their system that says something like submit to NHSN, and then that's how the files get to us, instead of it just cuts out the middleman process of you having to log into NHSN and use the import-export feature yourself. We do have a quick learn video for how to upload CDA files in NHSN. The link is here on the slide. I would highly recommend taking a look at that. It's very brief, less than 15 minutes long. So that just highlights the reporting plan and then goes through the process of manually uploading your files. All right, so doing the whole flow of the data now. So the data start out in the EMAR BCMA system. They are aggregated by the vendor or homegrown system into the monthly summary files by individual location or FACWIDE in for all 91 antimicrobials and your denominators of days present and admissions. Those data are put into the standardized format of CDA. They're uploaded into the NHSN servers, and then immediately after you generate your data sets, you are able to review those data using our analysis reports, and you can also share them via the NHSN group function. Once that happens, stewards can compare data internally, reviewing months against each other or locations against each other, or externally using our standardized antimicrobial administration ratios, or SAARs, which we'll get into a little bit later. If your facility is not yet participating, these are the very high-level steps we recommend following. So the first prerequisite, like we've already mentioned, you must have the EMAR or BCMA system for at least your inpatient locations. If you don't have it yet for your outpatient locations, that's okay. That can come along later. So then your next step would be to identify your facility lead or leads, or champions for the AU option. This can be one person, it can be many people, a team. Oftentimes it's the pharmacist or someone in infectious diseases, but it doesn't have to be. It can be someone in infection control as well. So your champions are fit all sorts, shapes and sizes. The next step of that person or the group would be to gain support within the facility. So obviously you're going to want support from your pharmacy folks, but also infection control, since they are kind of the keepers of NHSN right now. They have access to your NHSN facility and will likely be offering you quite a bit of support as you get up and running with submitting AU data. You're going to want support from your IT folks. So even if you decide to use a vendor system, your IT folks are still going to be involved in some level, so you'll want their support. And then obviously your C-suite, since they will likely be the ones signing off on any sort of additional vendor functionality or new vendor functionality. So the next step would then be to gather information on your current CDA submission capabilities. So some of you may be using a vendor software that offers this already, and maybe you just need to turn it on. Maybe you just need to start using it, and that's as simple as it is. Others may need to seek out a new vendor or an additional vendor to submit your AU data, and yet others will be developing the system internally. Then, once you have that, your data feeds are turned on, you would move into the validation section or portion of the participation. So we have very detailed implementation validation protocol that you can walk through. I have the direct link here on the slide for you, but you can find that on our website as well. So we highly recommend doing some sort of data validation prior to submitting data into NHSN. And then once you've confirmed your data are valid, you would move into your monthly submissions. All right, so next I'm going to cover the AU option analysis reports. So we have a lot of reports available for you. So that is evidenced by this very lengthy screenshot here. Try not to get overwhelmed. It is a lot of reports that are already pre-filtered for you. So just kind of moving through our report types, we have line lists and rate tables. Those reports are pre-filtered for you by most recent month of data submitted or by all months of data submitted, by individual patient care location or by FACWIDE in. And then for our rate tables, you can see the rates per category, antimicrobial category or class, or by selected drug. So you can pick and choose which drugs you want to generate the rates for. And then we have pie charts and bar charts. Those are also pre-filtered for you to get either the most recent month or all months of data. And you can specify specific categories or classes for those as well. And then we have our SAARs, our standardized antimicrobial administration ratios. Those reports can be generated for all SAAR locations combined or by individual SAAR locations. So first, let's cover a line list and kind of walk you through what that looks like. These screenshots show a default line list for the most recent month of data I had available in my test facility by location. So I do want to point out that all screenshots you see on this slide and any other slide in my presentation are for example only. They are fictitious data. So you'll notice that the default reports show NHSN variable names as the column headers. So some of these variable names may not be familiar to you. That's okay. You can modify the report and click to show more descriptive variable labels, which is what we would recommend doing for those of you that are just starting out in NHSN. It just gives you a little bit more clarity on what each of these columns mean. But this first screenshot I have highlighted here. You're seeing just the very top of the report for my pediatric surgical ward location, which is my location called Ped Surge in my NHSN test facility. This line list shows each drug as its own row in the report. So if I show the summary YM, that's the date variable column, that means September of 2018. These antimicrobial days are reported for the month of September of 2018. Next, I have my antimicrobial days column. That's my total antimicrobial days that were reported for each of those drugs. And then the last 4 columns in the report are the substratified route of administration. So you see 4 columns for each of the 4 routes. And then finally, in the middle of the line list, we have our denominators, our days present, and our number of admissions. I do want to point out that number of admissions, remember, is only submitted for FACWIDE in. So if you generate a line list for any patient care unit that's not FACWIDE in, you will see in the number of admissions column a little period or a little dot there indicating that that is not applicable. So to read this line list, my highlighted row here is saying that in September of 2018, in my pediatric surgical unit, amikacin was used for a total of 25 antimicrobial days. 20 of those days were administered via the IV route, and 5 days were administered via the respiratory route. So we have a number of different rate tables in NHSN. All of our rate tables show the rate of utilization per 1,000 days present or per 100 admissions, depending on the rate table. We have three types of rate tables highlighted here on the slide. So with the red box or the number 1 next to them, those are the rate tables for the SAAR-like agent groupings. So those are specific drugs that we've put in those rate tables that you cannot add to or you cannot remove from. They will always be the same drugs. The rate tables highlighted in the green box with the number 2 next to them, those are the rate tables that are defaulted to show the rates by antimicrobial category and class by location and time period. So those are our most basic rate tables. And then the rate tables on the bottom of the screenshot highlighted in the blue box with the number 3 next to them, those are the rate tables that allow you to select the specific agent. So you can pick a single drug, drugs within the same class, or drugs within multiple classes to generate a rate. So just to quickly orient you to our rate tables, this line in the rate table highlighted with the red box here says that in June of 2019, all of my inpatient locations combined, or FAC-wide in, used antimicrobial days at a rate of 1,318.571 days per 1,000 days present. For that same month, carbapenems were used in all my inpatient locations combined at a rate of 17.143 days per 1,000 days present. Okay. So my next few slides are going to talk about the standardized antimicrobial administration ratio, or SAAR. So for those of you listening to the live webinar today, I'm going to talk just high level about the SAAR and SAAR reports, and then my colleague Tyler will present in much more detail about the SAARs. For those of you that may be watching this recording from our website, you will want to refer to Tyler's presentation on our website as well. So just point to the standardized antimicrobial administration ratio presentation on the website. So what is a SAAR? The SAAR is a standardized risk-adjusted metric of antimicrobial use, which is currently available to all facilities reporting data to the AU option. It compares the observed antimicrobial days to the predicted antimicrobial days. So the observed antimicrobial days are just those that you've reported in NHSN. So those come from your records that you've reported into NHSN. The predicted antimicrobial days are calculated by NHSN using our standardized models. So where can you find more details? So again, if you're listening to the live webinar today, stay tuned. If you're listening to this on the recorded web page, you can find more information on our web page. Just look under training videos. You can find more information about the SAAR in our protocol or in the analysis resources section of the web page as well. This is very important to point out to you. So I have a whole slide showing this. For our SAAR baselines, we currently have 3 different types of SAARs that you can run within NHSN right now. Each of them has a different baseline covering different data years. So the 2014 adult and pediatric SAARs can be generated for AU data submitted from calendar years 2014 through 2018. We did an update to the adult and pediatric SAAR models in 2017, so that's called our 2017 baseline SAAR. So you can generate 2017 baseline SAARs for data from 2017 moving forward to the present. And then newly released this year are our neonatal SAARs, and those can be generated from data from 2018 moving forward as well. So how would you find the SAAR reports? So in the antimicrobial use and resistance module folder on the analysis reports page, you would click antimicrobial use data folder, and then the very top 4 reports are our SAAR reports. So you would select the specific SAAR you want to run and then click run report. So there are 4 SAAR reports shown on the analysis and reports page. So you would select the all SAARs report to see the SAARs rolled up to the location group level. So for example, that would give me 1 SAAR for my broad spectrum hospital onset or BSHO SAAR for my adult ICUs combined. But if I wanted to see that SAAR at the location level, I would select the report that says all SAARs by location, either adult and pediatric or neonatal. And that would give me a BSHO SAAR for my med-surg ICU, a separate one for my surgical ICU, and a separate one for my medical surgical ICU, for example. Okay, so just orienting you to the SAAR reports in NHSN. So this is a SAAR report by individual location. You can see in the third column titled location, that's where my locations are listed there. In my antimicrobial days column, that is my reported or observed use of antimicrobial days. The next column is my predicted use of antimicrobial days. And then the third to last column is the SAAR value itself. So just quickly orienting you to how to read the SAAR report. So my highlighted row here at the top of the table, my 5G North location reported 158 antimicrobial days in the broad spectrum antimicrobial agents predominantly used for hospital onset infections, or BSHO category. Based on the SAAR model, 62.248 antimicrobial days were predicted for that location. This tells me that I have 158 reported antimicrobial days divided by 62.248 predicted antimicrobial days, which gives me a SAAR of 2.538 for this location and month. And then based on the p-value and the 95% confidence interval, this SAAR is statistically different than 1. Okay, so that was just a very high-level overview of the SAARs. Remember, if you want more information, either stay tuned or click on that other recording for us. So in addition to running all of the default analysis reports, you can modify all reports in NHSN. So instead of clicking Run Report, you would click Modify Report, and that would pop up the Modify screen for you, and you would have a number of different modifications that you can make depending on the report you've selected. We have a lot of AU analysis quick reference guides. So these are 3 to 5 page documents that provide a high-level overview of what the report is, what an example type of report that you could run for your facility, which goes through some modifications that you could make that may be relevant to your facility. So they just provide a very quick overview of how to make some modifications and how to interpret those resulting output. So you can find all of our analysis quick reference guides at the link listed here on the slide. If you would prefer to analyze your data outside of NHSN, that is also an option. You can always export your data from NHSN into SAS, Excel, Access, or a number of different other data types. Alrighty, moving into reporting metrics. So as I mentioned earlier in the presentation, reporting into the AU option is completely voluntary at this time. However, we have over 1,500 facilities that have submitted at least 1 month of AU data into NHSN, and that is as of January 1st of 2020. So these facilities are located in 49 different states. You can see our bed size average is 211 with a median of 157. We have some very small and very large facilities submitting AU data. Of those facilities submitting data reported on their annual NHSN facility surveys, 70% of them consider themselves a teaching hospital. And then of all teaching hospitals, 53% consider themselves major teaching. This is a map of the percentage of facilities reporting at least 1 month of data into our AU option as of January 1st, 2020. So you can see we range from 0% in Wyoming up to 61% in Virginia. So I'll leave this slide here. I know it's a favorite from many to see how their state compares to those around them. Okay, so now lastly, I'm going to move into some reporting resources. So I've referenced already a lot of times in this presentation our AUR module webpage. We have so many great resources on that page for you. Highly recommend going to the link on this slide here, just clicking through some of our available resources for you. So I just wanted to quickly go through what's available for you. So if you were to go to our webpage under the training section, that's where you may have found this talk, or you will find it very soon. In addition to all sorts of other presentations that are related to AU and AR options, as well as the SAARs. We have 3 quick learn videos there as well. Those are all 20 minutes or less videos about very specific topics. You can find our protocol under the protocol section of the page. We have frequently asked questions. We have one for AU and then another for AR option. Those are extensive. So if you have a question after today's presentation that you don't get answers to, I would recommend first checking out our FAQ page. If you can't find it there, obviously email us at the help desk, but we have a lot of really great questions and answers there. We get those from the common questions we get in our NHSN inbox. So that's kind of how we come up with what lives on the FAQ pages. In the data validation section, we have great resources there for you. So I've already mentioned our data implementation validation protocol. We also have a data validation protocol for those that have already implemented and now would just like to validate on an annual basis. So we have something for you there. We have a data validation protocol for AR option as well. Under supporting materials, you'll find everything from specific user rights documentation for AU users to the reference document that we've mentioned earlier for meaningful use or promoting interoperability. And then finally, the analysis resources section of the page. There you'll find all of our quick reference guides, our QRGs for you about all the AR reports as well as, AU reports as well as AR reports. And then at the very bottom on the right side of the screenshot, you'll notice a little blue icon, the red arrow pointing to it for CDA. That will take you to the CDA page. While that CDA page is meant mainly for vendors, there are some helpful information. Just give you an overview if you're just looking to know just a little bit more about CDA as a normal user. You're welcome to go to that page, but for facilities that are going to consider implementing AU reporting internally, they will spend a lot of time on that page. So direct your colleagues to that page. So finally, I have just a few direct resources for you, the direct links to the AUR module protocol, the analysis quick reference guides, and the CDA submission support portal. So that's all I have for you today. If you're listening to the live webinar, we'll take questions at the very end of the talk, or we'll answer questions at the very end of the talk. You can type in your questions at any time. If you are listening to this presentation from the recording on our website and you have questions, if they're general protocol and submission questions, you're welcome to send those to the regular NHSN help desk at nhsn@cdc.gov. If you have technical CDA related questions, you can send those to the CDA help desk at nhsncda@cdc.gov. So thank you so much.
Hello, my name is Tyler Kratzer, and I'm a data analyst in the Division of Healthcare Quality Promotion at CDC, and today I'll be talking to you all about the Standardized Antimicrobial Administration Ratio, or the SAAR. So to start, we'll review some information on what the SAAR is, why it was developed, how to interpret it, all that good stuff. And next we'll discuss the 2017 baseline adult and pediatric SAAR models, followed by our new 2018 baseline neonatal SAAR models. After that, we will discuss how the SAAR can be used to assist antimicrobial stewardship, and discuss what some of our next steps will be in developing the SAAR. Firstly, for some background, the SAAR is a ratio of observed days of antimicrobial therapy to predicted days of therapy that is available to facilities that report data to the National Healthcare Safety Network's AU option from patient care locations for which there are SAAR models available. The SAAR was first developed in 2015 using data reported to the AU option in 2014, and it provides the quantitative foundation for the NHSN's Antimicrobial Use National Quality Forum endorsement. So as an observed and predicted ratio, the SAAR allows facilities to compare their AU to the AU of a standard reference population, which in this case is NHSN baseline populations from 2017 or 2018, depending on which SAAR model you're looking at. The SAAR numerator is observed days of therapy that is provided by reporting facilities, and the SAAR denominator is predicted days of therapy for a specified group of antimicrobial agents used in a specified patient care location or group of locations that are based on our negative binomial regression models that are developed using nationally aggregated AU data. So we developed the SAAR to enable antimicrobial stewardship programs and other users to measure and track antimicrobial use. Facilities can monitor antimicrobial days of therapy and rates of use, but these measurements do not take into account differences in risk between populations and should not be used for comparison of AU over time or across reporting entities. And so the SAAR was developed to enable risk-adjusted comparisons of AU over time and across entities that antimicrobial days of therapy and rates on their own cannot do. So SAAR values are always greater than or equal to 0. A SAAR value less than 1 indicates that antimicrobial use was less than predicted use. A SAAR value equal to 1 indicates that observed AU is equivalent to predicted AU, and a SAAR value greater than 1 indicates antimicrobial use was greater than predicted. Keep in mind, however, that the SAAR is not indicative of appropriateness or judiciousness in antimicrobial use because those are not measured in our models. For example, a SAAR above 1 that does not achieve statistical significance may still warrant further investigation into possible overuse of antimicrobials in that SAAR agent category. Also, a SAAR that is statistically different from 1 does not mean that further investigation will be productive. Our SAAR development process begins by determining which SAAR patient care locations are eligible to be included in predictive models. We then finalize SAAR agent categories with input from subject matter experts. We identify which factors we need to consider as risk adjustments for our SAAR models. And then we validate the AU and hospital survey data we have to ensure that our models are as valid as possible. Once we've validated our data, we begin the development of our predictive models. We model each category individually using negative binomial regression, assessing which location and facility level factors are statistically significantly associated with rates of antimicrobial use for each SAAR agent category. Factors that are found to be predictive of AU are included in our final models as risk adjustments. The final models that we develop are used to predict antimicrobial use, measured in days of therapy, for a specified location or group of locations over a specified time period. The predicted days of therapy always takes into account the number of days present over the specified time period for the specified location. You can find more information on locations, antimicrobials in each category, and SAAR types that are available in the AUR module protocol. So the National Quality Forum originally endorsed the SAAR in 2015 as a metric for public health surveillance as well as internal and external quality improvement. The 2017 baseline models were re-endorsed in the 2019 cycle, and the 2018 neonatal SAARs will be submitted for endorsement in a future cycle. So the first SAARs that I'll discuss are the 2017 baseline adult and pediatric SAAR models. So the referent populations for the 2017 baseline adult and pediatric SAAR models include locations that reported greater than or equal to 9 months of validated AU data. These included children's, critical access, general acute care, military, oncology, surgical, Veterans Affairs, women's, and women and children's hospitals. A wide range of hospital sizes are represented, and all teaching statuses that we have categories for in NHSN are also represented in these referent populations. 49 states and territories are represented in the adult referent population, and 29 states are represented in the pediatric referent population. Our adult referent population includes 2,156 patient care locations from 449 reporting facilities. Our pediatric referent population includes 170 patient care locations from 106 reporting facilities. The table here shows how many locations are in the referent populations by location type. For adults, we have medical, med-surg, and surgical ICUs, medical, med-surg, and surgical wards, general hem-onc wards, and step-down units. For our pediatric population, we have medical and med-surg ICUs, as well as medical, med-surg, and surgical wards. For the adult and pediatric SAAR models, baselined in 2017, we have SAAR models available for 8 SAAR categories. Broad-spectrum antibacterial agents predominantly used for hospital-onset infections, broad-spectrum antibacterial agents predominantly used for community-acquired infections, antibacterial agents predominantly used for resistant gram-positive infections, such as MRSA, narrow-spectrum beta-lactam agents, azithromycin for our pediatric units only, antifungal agents predominantly used for invasive candidiasis, antibacterial agents posing the highest risk for C. diff infection, and finally a category for all antibacterial agents. These tables show the factors adjusted for in each adult and pediatric model. Most variables are facility-level factors that come from the annual NHSN hospital survey. Due to the larger sample size in the adult referent population, there were more factors adjusted for in the final adult models compared to the final pediatric models. I'll give you a moment to look through the tables. Rate reports are available for agents that were part of the broad-spectrum hospital onset SAAR agent category, but were removed because they are used to treat extensively antibiotic-resistant infections. These 5 agents have extremely low rates of use in adult and pediatric SAAR locations, being used at a rate of 1.21 days of therapy per 1,000 days present in adult SAAR locations, and 0.65 days of therapy per 1,000 days present in pediatric SAAR locations. Because the use of these 5 agents is so low, there is little variation in use, and the majority of locations report 0 days of therapy. However, because these agents can be used to treat extensively resistant infections, they are protected in their use and therefore are of interest to many antimicrobial stewardship programs. Because of that interest, we included rate reports in our AU output options that include pooled rates by location for adult and pediatric SAAR locations, as well as the rate distributions using 2017 baseline data from the SAAR referent populations. So this slide shows an example of a rate report that would be produced for a facility's pediatric SAAR locations. The year and month is shown first. In this case, data from July of 2018 is shown. The SAAR type is then shown. For adult and pediatric units, only one rate type is available, the extensively antibiotic-resistant bacteria. And this one is obviously for pediatrics because it's just for pediatric units. Antimicrobial days are pooled days of therapy across eligible pediatric locations within the facility and across the 5 drugs included in this group. The number of days present are pooled across all locations in the facility or group of facilities, And the rate days present variable is the pooled rate of antimicrobial use per 1,000 days present, and it's followed up by the 95% confidence interval for the rate. Numbers in white are made up and meant for explanatory purposes only, so a rate of 49 is highly unlikely, but again, this is just made up data. Data in yellow, however, represent true values of the pooled rate distribution for our 2017 baseline referent population. As mentioned before, for pediatric SAAR locations, the pooled mean rate is 0.65 days of therapy per 1,000 days present. After that, in this report, we have a p-value meant to indicate whether your facility's rate is significantly different from the pooled mean rate of the referent population. This variable is called SAAR underscore p-val, but as a reminder, all the data presented here are unadjusted, and the variable name is called that because the same macro is used to calculate p-values in SAAR reports. After the p-value, we have 4 columns indicating values for the 25th, 50th, 75th, and 90th percentiles for rate, based on the 170 pediatric locations represented in our 2017 baseline referent population. Because use of these agents is so low, more than 75% of pediatric SAAR locations report 0 days of therapy, and only 10% of locations report rates greater than or equal to 0.29 days of therapy per 1,000 days present. So now I'll discuss the 2018 baseline neonatal SAARs. The referent population for the neonatal SAAR models baseline in 2018 include locations that reported greater than or equal to 9 months of validated AU data. These included children's, general acute care, military, women's, and women and children's hospitals. A wide range of hospital sizes and teaching statuses are represented, and 45 states and territories are represented in the referent population. Our 2018 baseline neonatal referent population consists of 324 patient care locations, reporting from 304 facilities. Level 1 units were not included in the referent populations due to low AU rates and high rates of missingness in the survey data. For Level 1 units with greater than or equal to 6 months of validated data, 10% of those hospitals responded in the annual survey that they do not provide neonatal care. Additionally, the fluconazole model does not include special care nurseries in its referent population. Our neonatal SAAR agent categories include a category for vancomycin, predominantly used for treatment of late onset sepsis, a category for broad spectrum antibacterial agents predominantly used for hospital onset infections, third generation cephalosporins, ampicillin predominantly used for treatment of early onset sepsis, aminoglycosides predominantly used for treatment of early and late onset sepsis, fluconazole predominantly used for candidiasis, and finally a category for all antibacterial agents. This table shows the factors that were risk adjusted for in the final neonatal SAAR models. Most variables are from the annual NHSN hospital survey and are facility level variables. Some of these variables are adjusted for using combined variables in the model, such as location type and acceptance of neonatal transfers for complex procedures. I'll give you a moment to look at the table. Similar to the adult and pediatric SAARs, there are rate reports available for specific neonatal antibiotic and location type combinations. These include ampicillin in level 1 units to treat early onset sepsis, aminoglycosides in level 1 units to treat early or late onset sepsis, and fluconazole in level 2 units predominantly used for candidiasis. These antibiotics are used at very low rates in these units, but are all valuable for antimicrobial stewardship programs, and these rate reports allow ASPs to track the use of these antibiotics. but keep in mind that the rates shown are for national comparison and are unadjusted rates. This slide shows an example rate report that would be produced for a facility's Level 1 neonatal SAAR locations. The org ID and time frame for which the rate is being calculated are shown first in the table, followed by the rate type, which in this case is aminoglycosides in Level 1 units. Antimicrobial days are pooled across eligible Level 1 nurseries within the facility, as are the number of days present. The rate is displayed in the column labeled Rate Days Present, and our days of therapy per 1,000 days present. The 95% confidence interval for the rate is shown after the rate. All numbers in white are made up data for explanatory purposes, and the rates shown here are highly unlikely. Data in yellow represent true values based on the pooled rate distribution of our 2018 baseline referent population. The pooled mean rate is 5.23 days of therapy per 1,000 days present for aminoglycosides in Level 1 units. The p-value is to indicate whether your facility's rate is significantly different from the rate of the referent population. The variable is called SAAR_p-val, but as a reminder, all data presented here are unadjusted, and the variable name is called that because the same macro is used to calculate p-values in SAAR reports. After the p-value, we have 4 columns indicating the distribution of the rates into the 2018 baseline neonatal population. We have columns for the 25th, 50th, 75th, and 90th percentile. The SAAR can be used to more effectively focus stewardship efforts, as well as be used to assess the impact of specific stewardship interventions over time. This is because, as a standardized metric, it can be used to compare AU in a specific location or group of locations at 2 different points in time. To give an example of how the SAAR can be used to focus ASP efforts, Hospital A notices higher than normal rates of azithromycin use during a time period of a few months. The team has a hypothesis that the overuse may be occurring in one of their pediatric units, but they want to confirm this before they dedicate the additional ASP resources that will be necessary to successfully intervene and return the usage to normal. The team can use the All SAARs by Location report in NHSN to determine where the overuse is occurring. The hospital's ASP team used the report to assess SAAR values for their 4 pediatric locations. They see that their pediatric surgical ward, location named PedSurg, shown in the column labeled Location, is using azithromycin at more than 10 times the predicted rate. The team then decides to further investigate the usage of azithromycin in this ward to see if the excess use is appropriate or not. If they find evidence of inappropriate use, that can be an opportunity to improve usage of azithromycin. This next example is to show how a hospital can compare SAAR values across 2 points in time. The same Hospital A has been undergoing efforts to decrease their use of broad-spectrum agents predominantly used for hospital-onset infections in their adult medical ICU. To assess the impact of their interventions, they want to compare the SAAR values for this antimicrobial category across 2 points in time. They find a decrease in the SAAR value for the ICU from 1.654 in quarter 2 to 1.327 in quarter 3. The team wants to know if this is a statistically significant decrease, so they use the NHSN statistics calculator for comparing 2 SIRs, which can be used for SIRs or SAARs, as they are both observed to predicted ratios. The team inputs both their observed and expected values for the 2 time periods, and the statistics calculator produces the relative ratio of the SAARs. The SAARs are statistically significantly different, as the p-value is less than 0.05, which is the customary cut point to determine statistical significance, and the 95% confidence interval for the relative ratio does not contain 1. However, they must be careful, as due to the large denominators typically found in the SAAR, statistical significance does not automatically mean that the findings are clinically significant or meaningful. Statistical significance is important but does not indicate clinical significance. In this particular example, there is a large change in the SAAR that likely is clinically significant. But just because you see a statistically significant p-value or confidence interval in your data, that alone does not prove a clinically meaningful change in antimicrobial use. If you'd like to see some more examples of how the SAAR can be used to improve antimicrobial use, more examples can be found at this website. In the example shown, a community hospital submitted a case example where they targeted a reduction in fluoroquinolone use. They describe how they used the SAAR to identify high fluoroquinolone use, how they intervened, and how they used the SAAR to monitor the impacts of the intervention on their overall antimicrobial use. And on another note, if you want to learn more about the tables that are available in the AU option, such as the rate reports and the statistics calculator, that information is also available in the NHSN section of CDC's website. So CDC and the Pew Charitable Trust have developed a guide for using AU option data and the SAAR to drive improvements in antimicrobial use in hospitals. This document details the process of identifying opportunities for improvement and using that AU data for action. Currently, we are in the process of publishing a manuscript describing our 2017 baseline SAAR models. Additionally, we will continue assessing new locations for which SAARs can be calculated, with a potential next step being developing SAARs for emergency departments. If you'd like more information on the SAAR, our group has previously published a paper on the 2014 baseline SAAR models in clinical infectious diseases. We also have additional training materials available on the CDC website. Thank you so much for your time and attention. If you are watching this webinar live, then we will be holding a Q&A session at the conclusion of this presentation. If you are watching this video online and have any questions, please send those to nhsn@cdc.gov. Thank you.